Welcome to the Individually Based Limitations Training. I'm Donita Booth.
And I'm Lynette Robin. We're from the APD Training Unit for Services and Supports, otherwise known as TUFS.
Today we're going to discuss the individually based limitation process and the role of the case manager in this process. Individually based limitations, or IBLs as we'll refer to them, go into effect on July 1st of this year. IBLs are included in the Home and Community-Based Service Rules.
Today we'll provide an overview of the home and community-based services, including some background and consumer rights specified in these rules. We'll define what an IBL is and how we will be rolling them out. We'll talk about HCBS rights that can and cannot be limited. We'll go over the case manager's role in approving and implementing IBLs, as well as the role and responsibilities of the provider. We understand that you'll probably have some questions as we go through this, and we've gathered the questions that have come in so far. We'll be asking those questions throughout, and you will see a case manager asking the question and a trainer answering them. We also know that we're not able to answer all of your questions in this training, so there will be regular Q&A conference calls scheduled over the next several weeks that will continue through next June while we roll this process out.
In 2014, the Federal Centers for Medicare and Medicaid Services, or CMS, established rules to regulate what home and community-based services should look like. Prior to these rules, only institutions such as nursing facilities and state hospitals had been regulated in such a way. Around the same time, more money was being spent nationally in HCBS settings than in institutions, highlighting the need for a common national standard. Let's get some acronyms out of the way first. HCBS is Home and Community-Based Services. HCBs are Home and Community-Based Settings, which in Oregon we call Community-Based Care Settings, or CBCs.
The HCBS rules were implemented to ensure that individuals in a CBC setting have the opportunity to receive services in a manner that protects their choice and dignity and promotes their integration into the greater community. These rights were established and have been rolled out over the last 5 years. The final piece of the rollout to the HCBS rules is IBLs.
As a quick refresher, CBC facilities include adult foster homes, assisted living facilities, residential care facilities, including those endorsed as a memory care community.
What about nursing facilities?
Nursing facilities are considered institutional settings per CMS, so they are not covered by the HCBS rules.
I already have several providers who feel the last batch of changes allowing 24-hour visitors was excessive. I'm worried about consumers who may be given move-out notices rather than the provider cooperating with these changes. We already have a shortage of adult foster homes and beds for our consumers. If they start getting evicted due to this rule, what's the plan to find replacement settings for these consumers?
First, a provider cannot issue a move-out notice in order to get out of allowing these rights. These rights are not strictly for Medicaid consumers, but are for all residents in any CBC setting. Also, this is not a new requirement asking providers to allow additional rights other than the ones they've already been allowing. This change is providing a way for them to get APD's consensus to a limitation and to document the IBL when the consumer has consented.
What about residents receiving services in their own home?
CMS allows us to assume that those consumers are already experiencing all of the HCBS rights. However, if we see a situation in which that is not occurring, we would need to take action through education and possibly a referral to APS if appropriate.
Just what are IBLs?
Sometimes, in order to keep someone safe and healthy, we may want to limit certain rights. Both the state and the federal HCBS rules require all alternatives to be attempted before asking for a limitation. Once that's been done, IBLs are a way for APD to review and formally document any limitation of HCBS rights for an individual when exercising that right creates a risk to their own or someone else's health and safety.
The HCBS freedoms and rights do not allow for the harm to others. We really need to be clear on the rights to individuals. The residents' rights do not trump the rights of others, especially others' health and safety. So the limitation could be to protect the health and safety of another individual, even if not needed to protect the consumer themselves.
Limitations are only needed when a provider or others want to limit a right that a consumer is trying to exercise and are only used as a last resort. The best scenario is that all residents can be supported to experience every HCBS right. As we all learned in the cognition training, everyone has the right to make poor and unsafe choices as long as they understand the risks and consequences of those choices and the choices don't interfere with someone else's rights, health, and safety. Because of this, IBLs are strictly for consumers who are unable to understand the risks and consequences of their behavior as determined by the cognition part of their assessment. Only those consumers who are assessed with a substantial assist or a full assist in at least one of the 4 cognition components may have their rights limited. The 4 components are listed here. In addition to being a substantial assist or full assist in at least one component, there must be a specific assessed health and safety need for the limitation. IBLs must be very person-centered and will be unique to each individual. Also, it's important to remember that we do not actually have the authority to take away someone's rights, so a key component of IBLs is that the consumer or their representative must consent to the limitation.
What about a consumer who has cognitive issues severe enough that they are not able to consent to an IBL and there's no representative or anyone else involved in their care? Can we still implement an IBL to keep them safe and healthy?
We are currently working on a policy solution to this situation when someone doesn't have a representative and we can't find someone to appoint as their representative. This process is being created and it will be rolled out as soon as a solution is finalized, which should be sometime during the rollout period. In the meantime, the provider can follow the process and request the implementation. Once the case manager determines the IBL is warranted, the provider can apply the limitation until we have a policy in place to get consent in these situations.
Could a case manager just sign the consent for the consumer in that situation?
Unfortunately, that's not going to be an option. You might remember that in 2017, a transmittal came out implementing the use of the APD 737 at all initial assessments and reassessments to capture who a person would choose as their representative if they could no longer make decisions about their long-term care. So if the resident does not understand the risks, they need a representative. If no one has been designated, is unable, or is unwilling to serve in this role, the form also serves as notification that we will appoint a representative. The case manager can seek a representative in the order prescribed on the form as allowed in the Oregon Administrative Rule, which states DHS has the authority to assign a representative when needed. We would need to ensure no conflict of interest occurs as the representative cannot be a paid provider. We've included links to the transmittal, the 737 form, and the OAR here.
Wait, does that mean we have to track down our consumers' relatives or friends? That could be really time consuming.
No, we are only expecting the case manager to seek options that they are aware of and able to contact.
The final option listed on the form is an advocacy agency or individual. This has not been fully identified or defined and may not be an alternative at the initial rollout. This option is intended to address the situation when there is absolutely no one in the person's life who can act in this capacity.
What if a consumer disagrees with the limitation?
If they are competent to make that decision, then that is their choice and it must be honored. They may face the consequences of their decisions, such as negative health effects or eviction.
So they could potentially lose their placement?
Possibly, if their behavior puts someone else's health and safety at risk, that would likely meet the move-out criteria. We will provide more information about representatives as additional policy is developed during the transition period.
There are a lot of unanswered questions when it comes to implementing IBLs, as we don't know where the road will lead until we actually start down it. We expect that it's going to be a small trail that will have few consumers with the need for a limitation. We also don't know exactly what IBLs to expect. Until we start seeing the need for specific limitations, it's hard to guess what they'll look like. So we don't have all the answers today. This is a process that we'll all be learning together as we run into different situations when determining if an IBL makes sense or if there are other alternatives available. This is one of the reasons that we'll be continuing the Q&A sessions for the full year of the rollout, to provide an opportunity to discuss them with a policy analyst as they come up. We'll also be maintaining a Q&A document that you'll be able to access on the Case Management Tools website. So, although we will be providing some examples throughout this training, it's hard to predict what the reality is going to be.
Let's talk about the timeline for the rollout. Because of Oregon's success in moving consumers from institutional settings to home and community-based settings, we've had one of the largest and most complex transitions to the new HCBS rules. Due to this size and complexity, the timeline for full compliance was extended from 2019 to March 17, 2022. IBLs are the final step in the HCBS rollout. The IBL rollout begins July 1, 2019. Providers will have this year to formally document any limitation, whether for Medicaid consumers or private pay consumers. During this initial year, providers will not be penalized for their lack of compliance. However, beginning July 1, 2020, any non-compliance can result in citations and penalties for the provider. Then, as of July 1st, 2021, any facility not able or willing to be in full compliance will be closed, thus setting us up for statewide compliance by March 17th, 2022.
So what does this mean to you? During the initial year of IBLs, beginning this July, case managers will be addressing possible limitations at each assessment, whether it's an intake or a reassessment. This will ensure that any consumer who needs an IBL would have one completed by July 1st of 2020, while avoiding the need to review every case at the same time.
Who's responsible to train the providers on the limitations?
Providers are being trained by staff from the Long-Term Services and Supports Policy Unit and the Safety Oversight and Quality Unit. This training has been going on for several years through provider conferences and training sessions. The IBL specific training has been going on for the past 5 months in these same formats. We will also continue to send out administrative alerts and provide ongoing training. But really, in a sense, all of us reinforce policy as we address each individual situation together. How many times will we educate a provider before we must close the home?
Beginning July 1st, 2020, providers must allow all of the rights, the same as any other licensing expectations, such as how they provide services, how often their care plans must be updated, etc. After July 2020, if they do not provide these rights to every consumer, they would first face civil penalties, and then if continued, as of July 2021, their facility would be closed.
What are these rights that we've been talking about? All consumers have rights to access services in settings with the following qualities. They must be a setting selected by the individual from available options. This would include options with private rooms. These options must be identified and documented on a person-centered service plan based on the needs and preferences of the individual and should be based on the available resources for room and board.
The setting must provide a legally enforceable residency agreement which ensures the individual has at minimum the same responsibilities and protection from an eviction that a tenant has under the landlord-tenant law.
The setting must facilitate individual choices regarding services and supports and who provides those services and supports.
Each setting must ensure the individual's right of privacy, dignity, and respect, from freedom from coercion or restraint, and be physically accessible.
The settings must also be integrated with and support access to the greater community. This includes opportunities for seeking employment, engaging in community life, controlling personal resources, and receiving services in the greater community.
The setting must optimize, but not regiment, an individual's initiative, autonomy, self-direction, and independence in making life choices, including, but not limited to, daily activities, physical environment, and with whom the individual chooses to interact.
These rights cannot be limited, not even if the consumer consents.
So which rights can be limited? You might remember from the May Case Manager webinar, we've been focusing on these 7 rights. The right to decorate or furnish their area as they please, the right to have a lock on their door, to control their own schedule and activities, to have visitors whenever they choose, to have access to food at any time, to select their roommate, and to be free from restraints. We've been focusing on these 7 because they are the only HCBS rights that can be limited with an IBL.
Over the next few slides, we'll be referencing a consumer satisfaction survey called the National Core Indicators, Aging and Disabilities, or the NCI-AD. This survey asks Medicaid long-term care consumers about their experiences while receiving services. This is a national survey that Oregon has participated in for the past 2 years. Although it is not directly related to HCBS or IBLs, several of the questions correlate to those rights. So we will be sharing information about the percentage of consumers who feel they are already experiencing each right. Now let's go into more detail about the specific rights that can be limited.
The first right that can be limited is access to food at any time. This really just means that the resident has the ability to store their personal food and eat it whenever they want.
Does this mean the provider has to have a full menu available at any time?
No, nor does it mean the provider must offer unlimited all-you-can-eat buffet. Providers are responsible for 3 nutritious meals and 2 snacks each day.
What about alcohol? Is that considered food, and would we need an IBL for limiting it if necessary?
CMS prohibits blanket limitations to rights. Limitations are handled at the individual level through the person-centered plan. Historically, we have allowed providers to have policies prohibiting the use of alcohol in the facility. At this time, that will continue, though it may need to change over the transition period. This is if applied equally to everyone in the facility. If a provider feels one individual needs to be limited, that would require an IBL.
Let's talk about a possible example. Jim experienced a TBI from an auto accident and is living in an adult foster home. At his last assessment, Jim was assessed as a substantial assist in decision-making. The provider suspects Jim has developed an allergy to peanuts. Jim's family and friends visit and bring him his favorite candy bar and other treats that have peanuts in them. After each visit, Jim develops a rash. Suspecting the allergy, the provider asks to limit Jim from having treats in his room.
Why don't we just have the family stop bringing him those treats?
We'll be going into that later when we discuss the full process a provider must complete prior to requesting a limitation, which does include attempting other options.
Here are the first NCI-AD survey results. When consumers were asked about their access to food at any time, the majority feel that they had that right. You can anticipate there will be few limitations needed in this area as well as several other areas, as most feel they already have these rights.
The second right that can be limited is choosing one's own roommate. This means that if a consumer agrees to share a room in their residency agreement, they should be given the courtesy of meeting and potentially rejecting a proposed roommate.
So if they just keep rejecting roommates, they could end up with a private room after all?
No, roommates cannot be turned down in order to obtain a private room. There must be a good cause for the rejection. If someone wants a private room, they would potentially need to move to another setting that has a private room available. Continually rejecting roommates without good cause can be a reason for a move-out notice. Generally speaking, the provider is entitled to fill the space, barring no good cause objections. Here's a possible example. Madge has moved into a residential care facility due to progressive Parkinson's disease. She has been assessed as a substantial assist in self-preservation and decision-making. Madge has elected to live in a facility that only has shared rooms. She refused the first roommate as they had a negative history and didn't get along, so she was offered other roommate options. Madge continued to reject potential roommates, not realizing she must accept them unless she has good cause. After rejecting the first one, she just continued rejecting them without realizing the potential harm of a move-out notice. The adult foster home provider asks for a limitation to this right as he would rather not issue a move-out notice because he knows the consumer is very happy and comfortable there.
When the NCI-AD survey asked, "Are you able to choose your own roommate?" you can see that there weren't many who felt they had that right, especially in adult foster homes. We have some work to do to ensure those consumers and providers are aware of and exercising this right. The next right that can be limited is freedom to control their own schedule and activities. This includes things like deciding when to go to bed or whether to sleep in or get up early. It could mean choosing a bath time in the morning rather than at night. It also means you can come and go as you please.
Flexibility about when to get a meal or where you can eat it is important to many individuals. You should not be bound to return to the facility due to their timelines, like the next meal or curfew time. If you are out over a regular meal period, you should be able to get a meal that's nutritionally equivalent of the last meal served when you return and want to eat. This means the facilities cannot charge a consumer to eat their meal in their own room, and they must be offered a meal similar to those provided in the dining room.
Facilities try to keep schedules and tell people when they are to have showers, etc. My understanding is that a client has choice. How are we to ensure they meet the client's need, and what should we do when they claim staffing prevents the client's requests?
Facilities must address consumer preferences and how their needs are met in the facility's care plan. If you learn that a preference is not addressed by their care plan, you can support the individual by bringing it to the provider's attention. If providers fail to make reasonable accommodations to meet consumer preferences, the issue can be elevated to the SOQ complaint team or the licensors.
How does the freedom to leave look in a locked residential care facility or memory care community? Does everyone in the facility need an IBL?
This goes back to a limitation only being needed if someone is attempting to exercise a right. A resident may never leave their room without assistance or may never attempt to leave the facility, so would not need an IBL in this area.
An example here is Ruth, who has dementia and she was assessed as a substantial assist in self-preservation. She leaves the facility and gets lost and has rolled her wheelchair into traffic. She has been returned to the facility by the police, and the facility is asking for a limitation that she can only leave the facility with a staff person or family member accompanying her.
There are a couple of questions in the NCI AD survey that applies to this right. As you can see in these graphs, most residents feel that they can control their schedule when it comes to deciding when to go to bed or when to get up. However, not nearly as many feel they are able to have their meals when they want.
The next right means consumers can decorate and furnish their own room or unit within the boundaries of the residency agreement. It's important to keep in mind that the residency agreement cannot be any stricter than what is the standard for rentals throughout the community.
Let's look at an example. Jose has always loved to go around town and find treasures to turn into art. Now he has been diagnosed with Alzheimer's, and due to a cognitive decline, he has begun bringing back items that are unsafe or unsanitary and using them as art. The provider requests approval to limit his right to furnish and decorate his space with things he finds around town.
This chart shows how consumers responded to the question about their ability to decorate and furnish as they desire. Again, the majority feel they are already experiencing this right. For those that don't, it may be because they don't have the resources to buy the decorations they would like, so we can't automatically assume providers are the barrier.
The next right, freedom from restraints, means a consumer can't be physically or chemically restrained without their consent. Using restraints has already been limited in Oregon with a similar approval process required. This has resulted in the decreased use of restraints overall. We hope to have the same effect on the limitation of HCBS rights. By creating a process through which a provider must attempt other options prior to requesting a limitation, we hope to see an overall decrease in any rights being limited. One thing to keep in mind regarding restraints: the provider must obtain an order from a physician or other qualified practitioner before using restraints. We do not have a graph for this area, as this topic is not included in the NCI AD survey.
Susie, who has had multiple TBIs, is a substantial assist in challenging behaviors and a substantial assist in ability to make self understood. The provider notices Susie clearly prefers to use bed rails as she gets anxious and agitated whenever they are removed. Her guardian consents to the use of bed rails.
The right to have locks on doors is about the right to privacy and that only necessary staff have a key to the lock. So by default, every room should have a lock for privacy and to protect belongings when the resident is out of the room. Providers can't assume someone should not have a lock before they have actually had the lock, which then resulted in a risk to health and safety.
For example, Travis has Huntington's disease and is a substantial assist in challenging behaviors. He locks his door out of habit whenever he leaves his room, but he consistently loses his key. Rather than asking for help, Travis looks for other ways to get into his room. The provider wants to disable the lock as Travis has injured himself and damaged property while trying to get into his room.
Per the survey, most consumers feel they are able to exercise this right. Most CBC facilities have already been required to have locks on every unit. The exception are the adult foster homes providers who are required to have them on all units by July 1st of this year.
The final right that can be limited is having visitors at any time. It is important to note it is the resident that has that right, not the visitor. If a visitor shows up at midnight and demands to visit, it is the resident who determines if they want a visit at that time.
Are visitors allowed to stay overnight when visiting the client in a CBC setting? If so, how frequently are they permitted to have 24-hour visitors?
Remember, visiting is not moving in. However, since consumers are allowed visitors at any time, visitors can stay the night. There is no limit to how often a guest visits. Already we have family members spending all day, every day with their loved one. The same is allowed at night. We would expect visitors to leave at times to go to work, school, or home. One measure of visiting versus moving in is that the visitor has a home to go to. Visiting would generally be less than 24 hours at a time. Exceptions would include when someone is in the process of dying or another situation that would justify a longer visitation. At the end of life, people may be visiting 24/7 for days, and we recognize that for what it is, true visiting. So we don't want to be literal about it being less than 24 hours.
If a foster home provider is unable to accommodate overnight guests, do they have a basis for issuing a move-out notice?
No, as long as they are visiting and not moving in, it cannot be limited unless there is a health or safety reason.
Are overnight visitations ever considered as a risk to other consumers in an adult foster home? How are they going to keep other residents safe if they're going to allow visitors at, say, 2 a.m.?
The residency agreement can include expectations such as a check-in policy for visitors, and all visitors and residents would need to abide by that, and other policies designed to protect everyone in the facility. These could include restricting noise and not allowing visitors to roam the facility unaccompanied or without positive purpose. Check-in cannot require a visitor to sign in, but the provider can document if they wish to maintain a visitor record.
If the visitor is disruptive or causes harm to other residents, that could be a reason for a limitation. As with all IBLs, it will be dependent on the situation. Is the resident competent? Can the resident control their visitors? Both moving someone in and harming others by not controlling visitors are potential reasons for a move-out notice.
Here is an example. George has a friend named Betty who likes to visit him on a daily basis. However, in the evenings, his friend can become very loud and intrusive, which sometimes includes breaking things and making other residents feel very uncomfortable. The adult foster home provider is limiting his friend to not visit after 8 p.m.
While it appears that there is some room for improvement in this area, the reality is that some residents may simply feel they want family or friends to visit more often than they do. It doesn't necessarily reflect a provider putting up barriers, limitations, or restricting visitors.
Now let's talk about how many consumers this new policy is likely to affect. We've already shown how the majority of consumers already feel they are experiencing these rights. For those few who don't, many still won't need an IBL. Here's a visual. This represents your caseload. The initial screening will rule out most consumers from qualifying for an IBL. The first question to ask is, as the need arises, does the consumer live in a CBC facility? If the answer is no, you're done and no IBL is needed. The next question is whether the consumer is assessed as a full or a substantial assist in any one of the 4 cognition components. If no, again, no IBL. Then, does exercising the right result in a risk to health and safety? If yes, the final screening question is if the consumer understands the risks and consequences. If not, only then will the provider need to begin the IBL application process. This is likely to result in very few consumers who will need a limitation.
Will there be any data collection of the percentage of those on long-term care services and the number of limitations?
We initially built in tools to capture that data, but decided not to implement them in order to minimize workload impact. Another way we want to limit workload is by the creation of a screening tool in Oregon Access. To get there, go to the Service Planning page and click on this button, which will bring up the actual IBL screening tool. Oregon Access will pre-populate the first button for you if the consumer meets cognition.
If the answer is false, as shown here, there's nothing left to do. No IBL would be needed. If true, you'll consider if the consumer is attempting to exercise a right which is causing a risk to their own or someone else's health and safety. Next, do they understand the risks? If yes to both, they are screened in for a potential IBL. This is not the approval process. It is simply a way to help you screen in or screen out which consumers would qualify.
This is what you've been waiting for, your role in all of this. Since the transmittal came out in 2017, you've been ensuring consumers and representatives are informed of their HCBS rights and confirming consumers are allowed to exercise those rights. You can click on the link to review that transmittal. Now, with the IBL rollout, the added steps include recognizing when a right is being limited or maybe should be limited. When that happens, you'll let the provider know what they need to do. Once they've done that, you'll review the information, determine if the IBL is warranted, and get the consent and signature.
How would I know if a right needs to be limited or is being limited?
You may observe something during an assessment or learn something while talking to the consumer or the facility during your directs or indirects throughout the year. You could use that time to ask questions related to these rights, not every right and not every time, but just while touching base with the consumer.
What would that look like?
Well, during your direct contact, you ask the consumer if anyone visits, has visitation ever restricted, maybe what their favorite snack is and if it's available.
There are some rights you'll never need to ask about. When it's clear they use the lock on their door, they fully decorated and furnished their area, and no restraints are being used, for example. Also, if the consumer is not attempting to exercise a certain right, there would be no need for an IBL. For example, if the consumer doesn't want visitors, doesn't want to lock their door, or have food available, we wouldn't need to consider a limitation. The right remains, but there is no need to limit the right or document an IBL because it is not the provider limiting or placing barriers to the consumer exercising their rights. Now let's review what the provider's role is.
The provider will need to identify when a resident is putting themselves or someone else at risk by exercising one of these rights. Once they've identified the need, they'll need to try other interventions and supports to try to resolve the risk without the need for a limitation.
When they determined the only option to keep the consumer or others safe is an IBL, they would approach the case manager, who would use the screening tools to see if the person meets the qualifications we talked about earlier. The case manager would let the provider know if the consumer is screened in so that they could continue the process.
You'll see that most of the process is the responsibility of the provider who is requesting the IBL. There are steps that a provider must go through before implementing a limitation. The process is designed to assist the provider in analyzing the need for a limitation.
Who will provide oversight and accountability to providers who are limiting our consumers' rights? And how will you know this is happening when cognition or verbal communication is impacted?
Over time, we expect that many eyes and ears of the system will be looking for these elements as expected practice. Case managers, family visitors, ombudsmen, surveyors, licensors, legal aid, advocates will all be watching and can report violations.
This is the APD 0556 form that providers are required to use prior to implementing an IBL for a private pay individual.
If it's for private pay, why are you showing it to us?
Good question. The first 2 pages could be valuable to you as a case manager as a way to let providers know what information you need in order to concur with an IBL. You could give this to a provider for them to complete. There are 2 additional pages that are used as a replacement for the service plan for private pay individuals. Those 2 pages would not be of use to you as you would use the SPAN. We'll review this process in detail over the next few slides.
First, they would need to describe the limitation being proposed. This piece is what will eventually be included on the service plan when approved, as you'll see later in the training. The provider will also need to include which right would be affected, who is requesting the limitation, at what time or in what circumstances would it be implemented, including how often and by whom.
A critical piece that you'll need to review is whether the limitation is proportional to the risk. For instance, in our earlier example of Jim, who had the peanut allergy, if the provider wants to stop him from having any food in his room, rather than just restricting food with nuts, that would be out of proportion to the risk.
Finally, we need an assurance that the interventions and supports do not cause any harm to the individual. The next step is to describe the reason for the limitation. You're looking for the specific health or safety risk that must be present before we can even consider an IBL. This would include how the provider assessed the need or risk. Remember, limitations cannot be for the convenience of the provider.
For example, if the facility wanted to prevent Ruth from going out into the community to prevent the wandering that is putting her at risk, that would be appropriate for an IBL. However, if Ruth was never in danger when she left, she just wandered around the neighborhood and the facility had to go find her when it was mealtime or time for her medication, if the provider then asked for a limitation, that would be for the facility's convenience and would not be appropriate for an IBL.
This is where we'll need to know what the provider has done to try to avoid the need for a limitation. Did the provider take reasonable measures to try to support the person in exercising their rights? The provider should attempt any and all reasonable interventions prior to considering an IBL.
How would we know what interventions could and should be tried?
Some possible interventions will be obvious, such as a referral to long-term care community nurse to educate Jim's family and friends about his allergy, or possibly by offering to exchange them for snacks without peanuts that he likes. Another excellent resource is one that is strongly recommended. It's Behavior Support Services. Only once their recommendations have been followed and failed would we truly know that they've tried every option.
The provider now needs to explain how this is the best option for the individual and why it makes sense for the situation.
This section is about monitoring once an IBL has been implemented. The provider must have a plan to measure the effectiveness of the IBL, including how we would know if a limitation achieved the desired results.
For example, if we limited Jim's access to snacks with peanuts and he continued getting a rash, was limiting the types of snacks in his room effective? No. Therefore, the limitation should be removed.
The provider needs to show how they'll collect that information as well as how often they'll review it.
Finally, these are the details for who will monitor the IBL and how long it will be in place. The maximum time a limitation can be in place without a full review is 1 year. However, IBLs should be monitored and removed sooner if possible.
For example, Ruth may develop a mobility issue that results in her no longer wandering, and therefore she would no longer need a limitation of leaving only when accompanied. Even though she's still dependent on staff to go outside, since she's no longer actively seeking to leave, an IBL is no longer needed and should be removed.
This step includes describing the plan for monitoring the safety, effectiveness, as well as the continued need for the limitation. Who is responsible to monitor? How frequently? How will the ongoing need be determined?
Back to the responsibilities of the case manager. Once the provider has completed their process and responsibilities, the case manager will then review all the information provided to determine if all steps have been followed and if a limitation is appropriate for that individual and situation. This includes ensuring the reason and limitation is clearly articulated, checking the proportionality, the interventions attempted, and that there is a good monitoring plan in place to ensure that it is effective.
Here is an optional form you'll be able to use as a checklist when reviewing that information from the provider. All of the questions we talked about on the previous slides and on the 0556 form are included here to assist you in determining if the provider followed the steps and the IBL is appropriate.
Once you've reviewed everything and it all looks good and you agree an IBL is appropriate and necessary, the next step is to have a discussion with either the consumer or their representative to ensure they are willing to consent to the limitation. Once you've done that, it's just updating the service plan and getting their signature. Let's see what that looks like.
This is what the service plan will look like on the span. You'll notice a box added for limitations to your HCBS rights. This is where you start. Once you click on that box,
this is the message that will appear. You'll notice that it informs the consumer that they can revoke their consent at any time. A consumer may initially agree to a limitation but may change their mind once it's implemented. For example, most of us have expressed a desire to live a more healthy lifestyle, exercise more, eat less, only to abandon the changes soon after. New Year's resolutions are often broken within a few weeks. APD consumers have the same ability to decide they no longer want to abide by a limitation, even if it is a healthier choice.
When you check the limitations box, this will also populate on the form. You'll see that there is a drop-down to include which right you are limiting, which looks like this. This is where you'll select which one of the 7 rights will be limited. Once you've selected the right, a drop-down will appear under Reason for Limitation that includes options applicable to that specific right. So for access to food, it may be medical risk, unsanitary, or other. Each right will include other as an option because, as we said earlier, we don't really know what this will look like until the requests start coming in. We also want these to be person-centered and unique to each individual.
For Jim with peanut allergy, we could use the option medical risk. Then we would use person-centered language to fill in this specific limitation. In this case, Jim will no longer have snacks with nuts in his room.
Here are the options for choice of roommate. For Madge, who kept rejecting roommates, we would select Rejections No Cause, and the specific limitation would be Madge has been unable to choose a roommate and the facility will do so for her.
Controlling own schedule and activities includes these options. For Ruth, who wanders, we would select Disoriented to Person, Place, Time, and Ruth will only leave the facility when accompanied by staff or family.
These are the options for freedom from restraints. For Susie, who wanted the side rails on her bed, we could use the option of Safeguards with Susie will have side rails on her bed.
You'll see that furnishing and decorating their area will usually be limited to unsafe or unsanitary decor. For Jose, we could use either. Listing facility will approve any new decorations Jose wants to bring into his room.
These are the options for removing the lock to a resident's room. For Travis, who kept losing his key, we would select Lock Self Out, Results as Harm, and state Travis will not have a lock on his door. Here we have the options for why we would limit visitors. For George, we would want to check Visitor Violent, Destructive, and state George's friend Betty will no longer visit after 8 p.m. And if they need more than one limitation, simply click on the green bar and another box appears. To remove a limitation, simply click on the red bar and the limitation disappears.
As mentioned earlier, an IBL can only be in place for a year before being fully reviewed to determine if there is a continuing need and the IBL is still the best option for the individual. Providers can and should review any IBLs at their regular care plans. This would be quarterly for assisted livings and residential care facilities and every 6 months for adult foster homes. The provider is responsible to give the information to the case manager to show a continuing need. The case manager would then make a determination if they agree to keep the IBL or if it should be removed. This is the end of the IBL application process. What else do you need to know?
As we promised, there will be regular conference calls to ask questions and discuss issues with the HCBS policy analysts. The first call will be held on Thursday, June 27th from 10 a.m. to noon. After that, there will be calls twice a month from July through September, then monthly for the remainder of the rollout year ending in June of 2020. There will be a transmittal coming out with the exact dates and times.
As we have these discussions, we'll be capturing the questions and including them in a Q&A document that will be posted on the Case Management Tools website. By making these answers available, we hope to avoid answering the same questions at every call.
Here are some resources and contacts that might be helpful to you as we learn this process together, including some links you can click on.
Thank you for your time. This concludes the IBL training.